Okay, and we're good. So hi everyone, thank you all for joining. Today's CE is a medication safety topic. So we're gonna be focusing on neuromuscular blocking agents. I have no financial interests or affiliations to disclose. For today's objectives for pharmacists, we're going to primarily cover appropriate indications for neuromuscular blocking agents. We'll also go through some sedation considerations and the reversal agents. We'll also discuss the ISMP, or Institute for Safe Medication Practice recommendations for handling these neuromuscular blocking agents, and then finally relate all of this information to clinical practice. For technicians, we're going to primarily focus on how to identify paralytic agents. We'll also discuss appropriate storage and labeling recommendations per ISMP, and also go through some of the parameters that we should monitor for following the administration of a paralytic. So before we get into our discussion, I just wanted to introduce this story to you. This was pretty popular in the media a couple years ago, so you might be familiar. This was actually a medication error that occurred at Vanderbilt. This involved a neuromuscular blocking agent, vecuronium. So this was about a 75-year-old woman. She presented to Vanderbilt with a headache and vision loss in her left eye. She was ultimately diagnosed with a hematoma, and 2 days into her hospital stay, the patient was scheduled for a full body scan. So the patient was already claustrophobic, so prior to her full body scan, the prescriber ordered a dose of Versed to try to relieve her anxiety. So the nurse who administered the medication to the patient went to pull it from the Pyxis, and she typed in the first two letters. So she just typed in VE, and nothing came up, and that was because the medication was listed under its generic midazolam. And because nothing populated when she typed in the first two letters, she engaged in override function and selected the first medication that popped up, which was the neuromuscular blocking agent vecuronium. So this nurse administered it to the patient without double checking what she pulled from the Pyxis, and then left the patient alone. So 25 to 30 minutes later, they noticed that the patient was unresponsive. She was found pulseless and breathless and was pronounced dead shortly thereafter. So the nurse who gave the incorrect medication is actually now being charged with reckless homicide due to this fatal medication error. So again, these medications are incredibly dangerous. They are high alert, and if errors are made, the consequences can be deadly, as seen through this example. So just to reflect on this story, I just want to point out the specific mistakes that were made, just so we can focus on how to prevent them from occurring in the future. So I think it's important to identify there were a lot of system errors that took place in addition to the nurse's reckless negligence. So the first mistake was that the nurse was able to utilize the override function to retrieve a high alert medication from her Pyxis. Additionally, she was searching by the brand name Versed when the medications were listed in the Pyxis as a generic, so she should have been looking for midazolam, and that led her to retrieve the generic vecuronium, which is our paralytic agent. She also did not check after she pulled the medication that it was the correct agent, and she didn't utilize barcode scanning prior to administering it to the patient. So all of these factors contributed to this terrible medication error that ultimately cost this patient her life. So it wasn't just the nurse's negligence. Yes, she was not practicing appropriate safe handling, but there were also a lot of system errors that allowed this mistake to occur. So once again, these are very high-risk medications. They require special handling to ensure mistakes like these aren't made. With that introduction, we're just going to switch gears and discuss these neuromuscular blocking agents in more detail so we can have a better understanding of what to look out for when we do discuss their safety considerations. So neuromuscular blocking agents are abbreviated NMBAs. They're also referred to as paralytics, and they exhibit their effects by working in the neuromuscular junction. So just to orient you on this picture, the neuromuscular junction is the intersection between the muscle fiber and a nerve. Again, just to orient you, we have the presynaptic nerve terminal and the postsynaptic nerve terminal. On the postsynaptic nerve terminal, we have various receptors. These are nicotinic acetylcholine receptors. Normally, acetylcholine flows from the presynaptic nerve terminal through the synaptic cleft and binds to these nicotinic acetylcholine receptors. So when this acetylcholine binds, it allows sodium ions to enter the cell, leading to depolarization of the membrane. So this generates an action potential that coordinates muscle contraction and muscle movement. So calcium and energy in the form of ATP is required for this muscle contraction to occur. So acetylcholine is then broken down by the enzyme acetylcholinesterase, which allows the channels to close and calcium to be transported back for the membrane to be depolarized. So this is actually the junction where our neuromuscular blockers work. So we have two different types of neuromuscular blockers. We have both depolarizing and non-depolarizing, and we'll just briefly go through the differences between each of these. So our depolarizing neuromuscular blocking agent works very similarly to acetylcholine. So it is an agonist at the nicotinic receptor. It attaches to the receptors on the postsynaptic membrane, causes the sodium ion channels to open and remain open. So this causes rapid and consecutive action potentials. So it essentially causes a prolonged depolarization of the cell. So this causes constant but diminished firing at the receptor, which leads to a hyperexcitable and hyperpolarized membrane. So the action potentials keep firing, and essentially they use up all of the calcium and ATP required to cause the muscle to contract. So essentially it leads to paralysis through hyperactivity at the membrane. So it overstimulates the nervous system. So what we see is a contraction followed by paralysis with our depolarizing neuromuscular blocking agents. So the mechanism for these are not quite intuitive. It's a little bit difficult to understand, but it essentially works in the junction by causing an overabundance of action potentials, which prolongs depolarization and ultimately leads to paralysis. Just a fun fact, the snake venom of the blue coral snake actually works this way. So the effects of the snake venom was actually described very simply in an article. So essentially the snake venom, which works very similarly to our depolarizing neuromuscular blocking agents, turn on sodium channels and keep them on, causing paralysis to take over the body by frying the nervous system. So again, this is much the same way as our depolarizing neuromuscular blockers. So you initially see contraction and fasciculations followed by paralysis. To help visualize what this contraction followed by paralysis looks like, I've included this video. Hopefully it plays for you guys. It's a video of the fainting goats. I'm sure you're familiar with it. It's really fun to watch. I'll just describe what this mechanism looks like. So the way it occurs in these goats is slightly different. However, the paralysis is a result of hyperactivity at the action potential. So I'll just show you briefly. So here you see the contraction followed by the paralysis. So again, the mechanism by which this occurs in the goats is slightly different than our depolarizing neuromuscular blocking agents, but it's a result of rapid and consecutive action potentials, which leads to overstimulation at the neuromuscular junction. So here you can see he almost fell off the table. That caused the contraction followed by the paralysis. And that just helps me kind of think about how these depolarizing neuromuscular blockers work. So our non-depolarizing neuromuscular blocking agents are competitive antagonists at the receptor. So the mechanism of these makes much more sense intuitively. So they bind to the nicotinic receptors and completely block acetylcholine from binding. And that leads to paralysis because it's unable to cause an action potential because we're blocking these receptors with our non-depolarizing neuromuscular blocking agents. So our neuromuscular blocking agents produce neuromuscular weakness and total skeletal paralysis by inhibiting normal activity at the neuromuscular junction. So paralysis first occurs in the small, rapidly contracting muscles. It then progresses to your fingers and your limbs, eventually to your trunk and intercostal muscles. And the last thing it paralyzes is your diaphragm. So these medications essentially cause respiratory arrest because you're unable to use the muscles in your diaphragm to breathe. That's why it's so important to make sure that if a patient is receiving these medications, that they are mechanically ventilated prior to administering them. It's also important to point out that neuromuscular blocking agents have no effects on analgesia or they have no anesthetic effects. So patients receiving these medications should be well sedated to prevent them of being consciously paralyzed. So even though these agents paralyze you, they do nothing to your awareness. So you still could have fear and anxiety. You could also have pain, and all of this can lead to significant emotional distress. So again, our two major classes of neuromuscular blocking agents are depolarizing and non-depolarizing. Our only non-depolarizing agent is succinylcholine. Our non-depolarizing agents can be further broken down into various subgroups depending on their structure. So as you can see, we do have a lot of different non-depolarizing agents, and we will go through specific considerations for these very briefly and their unique places in therapy. So in this table, I've actually included all of the neuromuscular blocking agents available on our formulary just to highlight some of the differences. So again, succinylcholine is our only depolarizing neuromuscular blocking agent. It has a very rapid onset and short half-life, so it's commonly used for rapid sequence intubation procedures. Something to note about succinylcholine, it has two very prominent adverse effects to be aware of. The first is that it can cause hyperkalemia. That is because it is a depolarizing agent. So when it depolarizes the membrane, it causes some efflux of potassium from the cell. It's also associated with malignant hyperthermia. This is a metabolic disorder. It's characterized by hyperactivity, muscle rigidity, and hyperthermia. So this is rare. It's thought to be related to a mutation in the intracellular proteins that regulate the release of calcium. For the sake of time, we won't go through malignant hyperthermia in great detail. There's a lot we could say about it. But for now, just know that succinylcholine can be associated with malignant hyperthermia. And if anyone does develop that, it's a contraindication to receiving succinylcholine in the future. So looking at our non-depolarizing agents, both vecuronium and pancuronium have metabolites with significant activity. So prolonged administration can lead to accumulation, especially for patients with renal or hepatic impairment. Because of this, neither of these agents are recommended for continuous infusion. So that just leaves us here with rocuronium and cisatracurium. So looking at both of these agents, they have minimal or no active metabolites. The major differences between these two is that rocuronium has both renal and hepatic metabolism, whereas cisatracurium exhibits non-enzymatic degradation in the bloodstream, which is known as Hoffman elimination. So choosing between these two agents for continuous infusion depends on the patient's comorbidities and if they have renal or hepatic impairment. Okay, so neuromuscular blocking agents are commonly used in surgery to facilitate intubation. They've also had some utility in preventing shivering during therapeutic hypothermia following cardiac arrest. And they can also be used in acute respiratory distress syndrome. So this is abbreviated as ARDS. And the reason why we're seeing so many more continuous strips of rocuronium and cisatracurium in our COVID patients is for their potential benefits in ARDS. However, there is some controversy regarding the use of neuromuscular blocking agents for ARDS. So this trial, it's neuromuscular blockers in early ARDS. It was published by the New England Journal of Medicine in 2010. It was a double-blind, multi-center trial, including patients with severe ARDS who are admitted to the intensive care unit. So they essentially randomized patients to receive the neuromuscular blocking agent, cisatracurium, versus control, and the endpoints they were looking at were 90-day mortality and death before hospital discharge. So essentially what they found was that patients randomized to the cisatracurium group had a lower incidence of mortality, and ultimately this led to the conclusion that for patients with severe ARDS, neuromuscular blocking agents may improve 90-day survival. There was a similarly designed follow-up trial known as the ROSE trial, which was conducted to retest the theory neuromuscular blocking agents improved 90-day mortality. So they essentially randomized patients with moderate to severe ARDS to receive cisatracurium versus control. And again, the outcome they were primarily looking at was 90-day mortality, but they also assessed organ dysfunction as well. Essentially what they found in this follow-up trial was that 42.5% of patients in the neuromuscular blocking group died versus 42.8% in the control. They also found that the neuromuscular blocking group had a higher incidence of organ damage, specifically cardiovascular disease, which ultimately led to the conclusion that there was no significant difference in 90-day mortality in this trial. So based on these two trials, the utility of neuromuscular blocking agents in ARDS is controversial. The mechanism of benefit remains uncertain. However, there is some discussion that it may prevent ventilator desynchrony. Also, it can decrease airway pressure and also reduce lung stress. So it's more so indicated to facilitate mechanical ventilation when sedation alone is inadequate to prevent this desynchrony. So the recommendation is that neuromuscular blocking agents may improve 90-day survival with those with moderate to severe ARDS if they are used for a short duration. So again, the reason why we're seeing so many more of our COVID patients on these continuous strips of rocuronium and cisatracurium is because we have many more patients on ventilators who are in moderate to severe ARDS at a very high risk of these ventilator desynchrony. So essentially the thought is that paralyzing these patients may help reduce airway pressure and also reduce some of the stress on their lungs. So again, the utility of neuromuscular blocking agents in ARDS is controversial. However, they are thought that they could potentially have some benefit in improving 90-day survival. Okay, so this leads us to our first knowledge check question. If you could just type your answer in the chat, we'll take a look at it. So our first question, non-depolarizing agents work in the neuromuscular junction by? And once again, just type your answer in the chat and we'll see. Perfect. Thank you. Thank you, Caitlin and Verona. The correct answer is B. They work as competitive antagonists at the receptor to cause paralysis. Which agent is a depolarizing neuromuscular blocking agent? Yep, it is C. Thank you, Tina. And which non-depolarizing neuromuscular blocker does not exhibit renal or hepatic metabolism? Okay, perfect. It's cisatracurium. And neuromuscular blocking agents have both sedative and analgesic properties, true or false? Perfect, yeah. So again, neuromuscular blocking agents cause paralysis. They have no effect on analgesia. They have no anesthetic effects. So it's very important to make sure these patients are adequately sedated. That's a very important consideration with patients who are receiving continuous drips of these neuromuscular blocking agents. So again, because neuromuscular blocking agents are high alert, there are several things that should be monitored for. Again, we discussed how these agents produce paralysis, but they don't affect your level of consciousness. So one of the most important considerations is ensuring that these patients have ample sedation on board. There's actually been a lot of studies showing that recall of events during paralysis is not uncommon. So this article was written to summarize some of the remembered experiences of ICU patients who receive neuromuscular blocking agents. So they essentially interviewed 11 different patients, and these patients just reported what they remembered while they were paralyzed. And essentially the general trends that they were able to recall was that they had thoughts of life or death. They also felt that they had no control. They had a sensation of fear and fighting, and that they were being tied down. So again, neuromuscular blocking agents can cause significant emotional distress, and if inadequate sedation is not used, these patients can actually recall these events. So there are many different ways to measure sedation. One of the most commonly used sedation scales is the Richmond Agitation and Sedation Scale, which is known as the RASS. So it ranges from -5 to +4. 0 is our reference point for someone who is alert and calm. The more positive you go on the RASS, the more agitated and combative you are. The more negative you get, the more sedated you are, with -5 essentially being a comatose patient, unarousable, no response. So for our patients on neuromuscular blocking drips, we want to target deep sedation, and that corresponds to a RASS of at least -4, and that's to try to minimize patient awareness and the concurrent emotional distress that being consciously paralyzed would definitely cause. It's also important to realize and to consider that performing a RASS on someone who's paralyzed is incredibly difficult. So this scaling system should be used in conjunction with clinical assessment to ensure that you're meeting the deep level of sedation that we should target. So a lot of times clinicians use this scale in conjunction to the patient's heart rate, blood pressure, diaphoresis, or even tears to evaluate if the patient has any pain or anxiety, just to make sure that they're adequately sedated. So regardless, it should be well documented in the order comments what type of sedation they are targeting, and it should be deep sedation. So whenever orders for paralytics are in the queue with these sedation orders, it's important to pay attention to the provider's sedation goals. So they generally put their sedation titration orders in the comments. So here you can see they put their titrate by 5 micrograms per kilogram per minute, and their goal RASS is listed here. Once again, if a patient is on a neuromuscular blocking agent, the RASS should be deep level of sedation, which corresponds to at least -4, to ensure that they are adequately sedated while receiving neuromuscular blockade. Another parameter that should be monitored is degree of paralysis. So essentially, they've seen that prolonged administration or overdosage of neuromuscular blocking agents may lead to accumulation and undetected paralysis. So the way that we monitor dose response to neuromuscular blockers and the degree of paralysis is by the train of 4. So this is a peripheral nerve stimulator. It's most commonly used on the ulnar or the facial nerve. So this nerve stimulator delivers 4 electrical impulses at 0.5 second intervals and then assesses the number of twitches that results. And that's used to help us determine how paralyzed the patient is. So when you increase the dose of neuromuscular blocking agents, the twitches begin to disappear when you perform this train of 4. So if you achieve 4 out of 4 twitches, it means that you're not paralyzed at all. 0 out of 4 twitches mean that you are too paralyzed and that the dose should be reduced. So for patients on continuous strips of neuromuscular blocking agents, our goal that we should achieve with the train of 4 is between 1 to 2 twitches, and that indicates that they are receiving an appropriate amount of paralytic. So I do have a short video here for you, kind of just demonstrating the train of 4. It's really difficult to hear, so I'll do my best to summarize what they're doing as they're going through this video. So they're just performing the train of 4 on someone who is obviously not paralyzed. So essentially they are just attaching the electrodes to the ulnar nerves. Okay, so there they go. They started to attach the electrodes, and they're putting it on the ulnar nerves. Again, they most commonly use the ulnar nerve or the facial nerve. And then they deliver the stimulus with the peripheral nerve stimulator. So take a look at the thumb. You should begin to see twitches. Okay, so they saw no twitches that time. So they're going to turn up the amplitude on the peripheral nerve stimulator. Okay, so we got 1, maybe 2 twitches that time. So we'll turn it up one more time. And there they got the 4 twitches. So again, the train of 4, they just deliver frequencies through the peripheral nerve stimulator, and they try to get 4 twitches. When you have a neuromuscular blocking agent on board, you want to target 1 to 2 twitches when you perform the train of 4. So just like our sedation titration orders, the train of 4 also has titration recommendations to ensure that the patient is receiving the appropriate amount of paralytic agent. So prior to verifying an order for a paralytic agent, you should also ensure that they have these titration order comments, that they're listed as such. Again, we target 1 to 2 twitches in our train of 4. So in addition to sedation titration and train of 4 monitoring, these patients should also have orders for DVT prophylaxis. They should also have a bowel regimen and eye care on board. So the reason for eye care is that neuromuscular blocking agents actually impair the ability to close your eyelid. That predisposes patients to developing ulcerations, infections, and even scarring of the cornea. So because of that, eye care in the form of petrolatum or ocular lubricants should be ordered for these patients. And then again, one of the most important considerations when utilizing these neuromuscular blocking agents is ensuring that the patient is mechanically ventilated. That's because it can paralyze the diaphragm and lead to respiratory arrest. So when verifying an order for a neuromuscular blocking agent, it might be worthwhile to give the entire profile a scan just to make sure that these additional requirements are being met. And if you're ever unsure if a patient is mechanically ventilated, it's actually really easy to tell in our order verification view. So I've just included a couple steps here just to go over how you might find a patient who is ventilated. So if you're on the patient's profile, you can actually go to results. In flow sheets, you can type in vitals view. If you want a quick way to get there, you can just type in V 3 times. Then you can go to vital signs and scroll down to oxygen therapy. So here this patient is on a ventilator and it's listed as such right under vital signs. So prior to verifying these orders, it might be worthwhile to check and just make sure that they are mechanically ventilated. Okay, so our next knowledge check question: which of the following is an appropriate sedation target for a patient on a cisatracurium drip? Perfect, yeah. Again, we want to target deep sedation, so that would correspond to a RASS of -4. Which of the following describes the train of 4? Perfect, yes. So the train of 4 is A, it's a peripheral nerve stimulator. It's used to monitor the degree of paralysis. Again, you try to target 1 to 2 twitches when you perform this train of 4, and that indicates that the patient is receiving an adequate amount of the paralytic agent. Question 7, titration comments for blink and blink should be confirmed prior to verifying orders for a neuromuscular blocking agent. Perfect, yes. So titration comments for train of 4 and sedation titration should be confirmed prior to verifying an order. Okay, so once again, before we move on, I just want to double check that everyone should have received an email by now with the slides. If you have not, just go ahead and indicate that in the chat and we'll send them out to you. You should have received an email from Tyler with the slides so you can follow along. So moving forward, how can we prevent medication errors from happening with this incredibly risky medication class? So the ISMP, or the Institute for Safe Medication Practices, is a nonprofit organization which is dedicated to medication safety. So ISMP actually works very closely with the FDA and collaborates about emerging and ongoing medication safety issues to discuss risk reduction strategies. So essentially the mission of ISMP is to analyze the reports of medication errors and near misses. They also determine risk reduction tools and identify various error prevention strategies, and finally work to disseminate all of these strategies to educate healthcare professionals regarding safe medication practices. So ISMP has a lot of different roles, but essentially its mission is centered around medication safety. They actually publish reports to help guide medication safety practices, and they've published several reports that are dedicated to the safe handling of neuromuscular blocking agents. So there have been well over 100 different incidences of medication errors reported to ISMP involving neuromuscular blockers. The most common error was administering the medication to the wrong patient or to a patient who is not mechanically ventilated. So again, we know these effects can be detrimental. It can cause respiratory arrest because these medications can paralyze the diaphragm if their patient is not receiving mechanical ventilation. So an analysis of the reports actually showed that neuromuscular blocking agents were administered in place of the alternative medication in nearly half of all reported errors. And in these cases, it made it to the patient in approximately 80% of the cases. So that's exactly the type of error that happened at Vanderbilt. So the patient was not ventilated and she received the neuromuscular blocking agent vecuronium instead of Versed. And that led to respiratory arrest because she was not mechanically ventilated, because she was not supposed to receive the neuromuscular blocking agent at all. So based on this case and other reports, ISMP has developed several strategies to reduce errors with this very high-risk medication classes. So we'll go through all of these strategies in more detail to discuss ISMP's specific recommendations to help reduce future errors with this medication class. So the first risk reduction strategy from ISMP is to standardize the storage of these medications. So there's actually been several errors and near misses attributed to how these medications have been stored. So I've included 2 examples of reports to ISMP here. So in one case, atracurium was administered to several infants instead of the hepatitis B vaccine. This led them to develop respiratory arrest, and that was primarily because the vial was inappropriately stored in the refrigerator in the PICU. In another case, a patient almost received a vial of atracurium instead of sterile water because someone inappropriately stored it near the vials of sterile water and they just happened to look alike, so this patient received it by error. So based on these reports, ISMP recommends limiting access to neuromuscular blocking agents and only storing them on very specific units, such as the emergency department, the operating room, or the critical care units. So not all units should have access to these agents. ISMP also recommends limiting the number of neuromuscular blocking agents that we have available on our formulary and segregating the storage of these agents so they're not accidentally confused with other medications. So regarding segregating the storage, if they're stored in the pharmacy, ISMP recommends storing them in a separate container in an isolated area away from the other stock. If they're stored on the units, ISMP recommends placing them in a specific box, in a rapid sequence intubation kit, or in individual baggies that have a lot of warning and auxiliary labels, making it very obvious that it is a paralytic agent. If they're stored in anesthesia carts, ISMP recommends organizing them in a very specific way so that vials that may look alike are not stored next to each other. And this is just to avoid inadvertent administration of look-alike vials if someone is in a hurry. ISMP also has specific recommendations regarding labeling to avoid look-alike, sound-alike medication errors. So ISMP recommends using the brands of neuromuscular blocking agents that have very clear labeling on the external label and the lid, which indicates that it is a paralyzing agent. ISMP also recommends placing auxiliary labels on all storage bins and final medication containers, indicating that it is a paralyzing agent, which could cause respiratory arrest. So again, ISMP, the recommendations for labeling is just to make it as obvious as possible that it is a paralytic agent to just prevent inadvertent administration to someone who is not ventilated. So here's an example of some of the labeling that we utilize here at Stony Brook. So we have these bright yellow auxiliary labels, which state warning, paralyzing agent. And we have these specific bags. So if the paralyzing agent is going up to the unit, they're sent in these bags. And very clearly on the outside of the bag, it says warning, paralyzing agent may cause respiratory arrest, patient must be ventilated. So it makes it very obvious when handling these medications that it is a neuromuscular blocking agent, and it should only be administered to patients receiving respiratory support in the form of mechanical ventilation. So our next question, to minimize medication errors, neuromuscular blocking agents should be stored. Perfect, yes, they should be stored segregated from other medications. Okay, another potential area for medication errors regarding these agents is incorrect orders. So this primarily includes orders that were intended for a different patient, the knowledge gap regarding the need for mechanical ventilation, and inappropriately used terminology. So ISMP's recommendation for preventing these types of errors is to make these neuromuscular blocking agents part of a protocol or an order set to ensure that they are only distributed to patients who are also mechanically ventilated and that the sedation targets are appropriately met. So we actually don't have a specific power plan for neuromuscular blocking agents here, but we do have other safeguards in place to ensure that these parameters are met. And that's the documentation of the GOL-RAS and the order comments, and also the quick and easy way to check if a patient is mechanically ventilated in our order verification view. Regarding terminology, ISMP just recommends utilizing very consistent and clear terminology for these agents. They state that you should only refer to them as neuromuscular blockers or paralyzing agents so that everyone is on the same board. So they recommend never referring to these agents as muscle relaxants because that can cause confusion and it may lead to communication errors. So if you're ever discussing these agents, it should be referred to as neuromuscular blockers or paralyzing agents. Muscle relaxant is not an appropriate way to refer to these medications. Finally, one of the biggest sources of errors with this medication is centered on how they are able to be searched and extracted from the Pyxis. So that was a critical error that occurred in the Vanderbilt story, and it was essentially how the medication was removed by the nurse from the Pyxis. So just a reminder, she typed in VE for Versed, and instead she got vecuronium. And that was because the Pyxis was configured to list medications by generic. So based off of this specific event, ISMP recommend configuring the Pyxis to allow searching by both brand and generic names if possible. And if it's not possible to add that feature, they just recommend extensive education to the staff as to how they should be searching for these medications. Another error that occurred in the Vanderbilt case was that the nurse was allowed to override a very high alert medication and remove it even though it was not what the provider ordered for the patient. So because of this, ISMP recommends managing the list of medications that can be override by the Pyxis and also requiring a witness when any medication is overridden. And this is just to prevent removal of an incorrect medication. So the witness is actually required to put in their credentials to verify the patient, the medication, the strength, and the route, as well as the indication to ensure that these medications are used appropriately and that the override feature is used appropriately. And finally, one of the most detrimental errors regarding these agents is administering them to someone who is not ventilated. So ISMP's strategies to avoid this type of error is to ensure that you're only dispensing this medication to an area that can support mechanical ventilation. Again, that would be our emergency departments, our ICUs, and the operating room. So whenever you're verifying an order for these medications, you should always just stop and look at where the medication is going to ensure that it is an area that can support a mechanically ventilated patient. And finally, one of the last recommendations is to always utilize barcode scanning. This is more so a recommendation for nursing, but it's just the final check to ensure that it is the correct patient receiving the correct medication. So even with all of these safeguards in place, errors can and have occurred. So what should you do if you give a paralytic to the wrong patient or to someone who is not mechanically ventilated? So we happen to have several agents available to reverse the effects of neuromuscular blocking agents. So our first reversal agent is neostigmine. This works by inhibiting the destruction of acetylcholine by inhibiting acetylcholinesterase. So this allows more acetylcholine to be available to compete for the receptor. So it has an indirect mechanism of reversal, and because of that, its predictability is not the best, and it can't be established in all of the cases. So additionally, because neostigmine increases the amount of acetylcholine, it's associated with cholinergic side effects, including bradycardia, increased salivation, and nausea and vomiting. So it's not always very pleasant and not very well tolerated by every patient. Our next reversal agent is sugammadex. This forms a complex with our neuromuscular blocking agents, and it impairs their activity at the receptor. So sugammadex is specific for rocuronium and vecuronium, and it has more predictable reversal compared to neostigmine. So just comparing our available reversal agents, neostigmine again is a non-selective reversal. It will reverse all non-depolarizing neuromuscular blockers, but its efficacy is unpredictable due to its indirect mechanism of reversal. Again, it also has a lot of side effects. Again, these are cholinergic, specifically bradycardia, hypotension, postoperative nausea and vomiting. So it may lead to reduced tolerability and the potential to utilize other medications just to manage the side effects. Sugammadex, on the other hand, is selective for both rocuronium and vecuronium. It is associated with faster reversal time, and it has more predictable reversal as well as a better side effect profile. So this article was a systematic review summarizing 41 randomized controlled trials. And the primary outcome that they were looking at was recovery time from neuromuscular blocking agents. They were specifically looking at recovery from rocuronium using reversal with neostigmine compared to sugammadex. And the secondary outcomes they were looking at were adverse effects. Essentially what they found was that sugammadex was associated with faster reversal time compared to neostigmine, and that neostigmine had more significant adverse effects. Again, those were the cholinergic effects that we already discussed, such as bradycardia and nausea and vomiting. So ultimately, this led to the conclusion that sugammadex allows for faster reversal and fewer side effects. So there's a lot of additional literature supporting the use of sugammadex, specifically post-operatively, showing that it is associated with quicker recovery time. It also has a shorter time to extubation, reduced likelihood of residual post-operative paralysis, and reduced frequency of adverse effects. So for these reversal agents, ISMP recommends keeping them accessible to all units that regularly store these agents with instructions available on how to administer them. And this is just so that these agents can be available to reverse neuromuscular blockers as quickly as possible in the event that a patient receives the medication in error. Okay, so I know we talked about a lot of different things today, but just to summarize the key points, neuromuscular blockers produce skeletal muscle paralysis by acting on the receptors in the neuromuscular junction. Again, we have two different classes. We have depolarizing neuromuscular blockers and non-depolarizing neuromuscular blockers. Whenever a patient receives these medications, they should have ample sedation as well as mechanical ventilation because these medications may lead to respiratory arrest. Again, these medications are extremely high risk. However, ISMP has many strategies to help prevent errors with this medication class. So before we get into our post-assessment questions, does anyone have any questions before we move on? And again, you should have received an email from Tyler. This has all of the questions at the end, and as well as the links to how to access these questions. We'll go through them all just to see if we can clear up any concerns or if you have any questions about our post-assessment. Okay, so I'm not hearing anything. Again, you can unmute yourself if you don't want to type into the chat. You can unmute yourself and ask your question that way. If not, we'll go ahead and get into our questions. So let me just end the recording before we